discrimination persists in the United States. I'm going to pick an example far removed from high-quality scientific evidence, but I think it makes my point, and then I'll look at some of the scientific evidence. You might remember this. April 25, 2012, the 7th game of the first round of the 2012 Stanley Cup playoffs. Boston Bruins, defending champions, playing at home. Their fans certainly expected the Boston Bruins to win. The game went to overtime, and it just so happened that Joel Ward, playing for the Washington Capitals, scored the winning goal in overtime. What's stunning is what happened in response to that, is what happened on Twitter. And I will not even dignify all the comments by reading them, and these are just a few examples of the spontaneous response of Bruins Nation to the loss that was quite striking. And what does it say about us that people were saying things like the fact that a black person scored the winning goal made it hurt a lot more? I'm not a clinical psychologist, but I think we need some clinicians here to think through the pain that people went through and the fact that the pain was so much harder. Okay, that's not really strictly scientific information. By the way, I have other examples of that from President Obama speaking in Newtown, interrupted the Sunday night football. You should see the tweets that came out in response to that. What scientific evidence we have of the persistence of discrimination in society? The best evidence comes from what are called audit studies. In an audit study, you hold everything constant. The only thing you vary is race. Deva Pager, a sociologist from Wisconsin at the time, did an audit study in Milwaukee, Wisconsin. She took 2 white males and 2 African-American males and sent them to apply for entry-level jobs in Milwaukee. They were judged to be of equal attractiveness. They had identical resumes. The resumes were identical. But she had one of the white males and one of the African-Americans say that he was out on parole and had served an 18-month prison sentence for cocaine possession. So one had a criminal record, one didn't. Deva Pager found what you would expect to find. Whether you were white or black, here's for white. If you had a criminal record, you were less likely to get a call back for a job. Okay? No criminal record here, 34% versus 70% if you had a criminal record. But what she found was what no one expected to find. And it was this. It was easier for a white male with a criminal record to get a call back for a job than a black male whose record was clean. The resumes were identical. Deva Pager repeated the study in New York City, looking at African Americans, Latinos, and blacks, and found the same thing. This is the callback rate, 17% of whites with a felony conviction got a callback rate, compared to 15% with a Latino with a clean record, and 13% for an African American with a clean record. How on earth do we make sense of that? Another study that was done was the researchers went back 30 years in the state of Massachusetts, looked at the names that white parents give their children, looked at the names that black parents give their children. There was overlap with the names, but it tried to identify the names that were almost exclusively used by white parents and names that were almost exclusively used by black parents. And then they didn't have the persons go and hand in the resume, they mailed the resume in. So the only clue about race is the name. And what they found was white names, distinctively white names like Allison, Emily, and Brad, did much better in getting callbacks for jobs, so 50% better, than distinctively black names like Letitia, Aisha, and Jamal. So I could go on and on. There are tons of studies like that that document the persistence of discrimination. These are not 1960s studies. These are all relatively recent studies. Okay, so does discrimination matter for health? Do these experiences of discrimination, all of which individuals may not be aware of, but to the extent that you are aware of being treated unfairly or badly, does that have health consequences? The evidence on that is very good. So I recently did a review found 150 new studies published just between 2005 and 2007 in the PubMed database alone. That's just in the medical literature, not all in the social science literature, for example. The field has matured. We have longitudinal data. We have data that has now adjusted for the psychological confounders like neuroticism and self-esteem and social desirability bias. Even when you adjust for these things, it still predicts. We now have the research in discrimination in health has gone global. We now have data from New Zealand, Sweden, South Africa, Australia, virtually every Western European country looking at immigrant groups. And what the research finds is that discrimination is not only linked to poorer mental health, but it's related to a broad range of measures of physical health status, such as higher levels of diabetes risk, higher levels of substance abuse, linked to breast cancer incidence, linked to fibroids, linked to subclinical carotid artery disease, which is a measure of the development of heart disease in your arteries, and it's linked to how minorities actually access health care. Persons who report high levels of discrimination, even outside of the healthcare system, it affects how they function within the healthcare system. And importantly, research now from the United States, South Africa, New Zealand, and Australia shows that this residual effect of race, when you look at groups at the same level of economic status, discrimination helps to account for some of that residual or additional effect of race. So we now know that racism really matters. Let me give you a concrete sense of this work by focusing on one measure of discrimination, a scale that I developed called the Everyday Discrimination Scale, and I want to focus on one researcher and some of the findings she has had with that scale. So what I tried to do in the Everyday Discrimination Scale, and it was based on reading the qualitative work of sociologist Joe Fagan and Philomena Essed, a Dutch scholar. They argued, and clearly Philomena Essed argued, the discrimination was not just in the big things that happened, but it was patterned into the everyday reality of life. And so the scale asks questions like, in your day-to-day life, how often are you treated with less courtesy than others? How often are you treated with less respect than others? How often you receive poorer service than others in restaurants and stores? How often do people act as if they think you are not smart? How often do people act as if they're afraid of you, and so on? So it's just the little indignities. Kenny Lewis, until recently at Yale University, looking at the Everyday Discrimination Scale, these are just some of the findings, just showing the power of it, just from one researcher with one measure of discrimination. High levels of discrimination linked to higher levels of coronary artery calcification. That means you literally, it's a measure of subclinical heart disease. High levels of C-reactive protein, that's a very commonly used measure of inflammation, and inflammation matters for heart disease and a range of the ability of your body, how well it's functioning. High levels of blood pressure. Women who, while pregnant, experience this everyday discrimination, they give birth to lower birth weight infants. High levels of discrimination among the elderly, more rapid declines in cognitive functioning. High levels of discrimination, poorer sleep, both objectively assessed as well as subjectively assessed. Importantly, high levels of discrimination, higher mortality. Discrimination literally is killing people, adjusting for other standard risk factors. And probably the most fascinating study Tene Lewis did was high levels of discrimination linked to high levels of visceral fat. Now, visceral fat is one type of abdominal fat. We all know we are an obese nation, and that high levels of abdominal fat is bad for us. But what we know from the medical literature is that there are two types of abdominal fat. There's subcutaneous fat and the visceral fat. Visceral fat is a deeply embedded fat within our organs. It is the bad type of fat. And what Tene Lewis found was that discrimination was unrelated to visceral fat. It's unrelated to subcutaneous fat, sorry, but predicted high levels of visceral fat. Intriguingly, she found that discrimination predicted higher levels of visceral fat for both black and white women who reported high levels of discrimination, which allows me to make a really important point about the Everyday Discrimination Scale and the measures of discrimination that I have developed. I apply them to anybody. You don't have to be a minority to receive them. What we find is that minorities report higher levels of discrimination, but whites report discrimination too. And we find similar effects. Attribution doesn't even matter. Once you report these negative experiences, it has consequences for health, which is an important take-home point for us because it suggests that the higher levels of incivility in our society and treating people as less than actually has consequences for how we all function as individuals. But it's powerful, just Tenny Lewis's work alone, this slide alone is powerful evidence of the extent to which discrimination has a broad range of negative effects on health. Let me just move on quickly. Give you another example of work on discrimination. I've been working with Brandisha Tynes, and she has conducted the first study of online discrimination in the United States. And what we have found is that in online contexts, chat rooms, text messaging, online games, social network site, there's a lot of racial slurs and negative attributes being reported by individuals, and that online racial discrimination adversely affects the mental health of adolescents. These were middle and high school students we studied in the metropolitan Chicago area, independent of other measures of offline discrimination and other general measures of adolescent stress. So online discrimination is making a unique contribution in adversely affecting the health of individuals. Let me talk about another mechanism of discrimination really quickly: internalized racism. Acceptance of society's negative characterization can adversely affect health. Here is national data from the General Social Survey. It's 1990 data, but things haven't changed dramatically since then, so I don't have time to show you the change over time. But the General Social Survey is a large national study done by NORC at the University of Chicago. It found that 44% of whites believe that blacks are lazy, 56% of whites believe that blacks prefer to live off welfare, 51% believe that blacks are prone to violence, and 29% that blacks are unintelligent. What I'm showing you here is black perceptions of blacks compared to white perceptions of blacks. So here, for example, you see that 44% of whites believe that blacks are lazy, 18% of blacks believe that blacks are lazy, and 56% of whites believe that blacks prefer to live off welfare. 35% of whites believe that blacks prefer to live off welfare. You get the point? So what I'm saying is these are stereotypes. Some stereotypes have a grain of truth, but they become generalized in terms of how we view an entire group. And the data suggests that some African Americans also believe the negative stereotypes of blacks. In fact, Jerome Taylor at the University of Pittsburgh his whole career has been devoted to studying internalized racism, and he finds that 1 in 3 blacks in his studies score high on internalized racism. What are the consequences? Higher scores in internalized racism linked to higher levels of mental health problems and higher levels of substance abuse. So he finds that internalized racism is actually consequential for health. I found it intriguing that a study in Australia looking at Australia Aboriginals also found 1/3 of Aboriginals scoring high on a level of internalized racism, and internalized racism also having adverse consequences for health. I want to talk briefly about research on stereotype threat, which is one way in which internalized racism can affect health. So Claude Steele, who really pioneered a lot of the work in this area, took African-American undergraduate students, good enough to get into Stanford University, divided them into 2 groups randomly by the flip of a coin. One of them was told to take a test. The other group was told, take this test, and blacks do more poorly in the test than whites. The group told that blacks do more poorly on the test did more poorly than the other group. This effect is so robust that Claude Steele can produce it simply by randomly dividing the black students into 2 groups. One group told take the test, the other group told take the test. Write your race on the top of the paper before you begin the test. Just having to write their race, making their race salient, leads to poorer academic performance. Claude Steele shows it's not about being black. It's about the society in which you live and the stereotypes that exist about your group in the society. So he's produced the effect among white women. If he brings 2 groups of white women in, one group is told take the test, the other group is told take the test, and women do more poorly than men. The group told women do more poorly does more poorly. He shows he can produce it among white males. If he brings 2 groups of white males in and tells one take the test, the other group told take the test, and men and whites do more poorly than Asians. The group told that whites do more poorly than Asians does more poorly than the other group. So what it takes to trigger it is the negative stereotypes about your group. So it has to be in an area where what he says your group is stereotype vulnerable. So for example, it doesn't work among white women if the test is about verbal skills as opposed to quantitative skills. Because the stereotype is women do better than men on verbal skills. So it doesn't work, doesn't negatively affect their performance. He's actually, in some recent studies, not he did, but some other researchers did, produced the effect among Asian American women. If they make gender salient that you are female, it leads to worse performance. If they make that you are Asian salient, it leads to better performance. So it shows it can even be manipulated. One of the most intriguing studies by Claude Steele and one of his students is that illustrates the role of socialization in your larger society is a study they did with black Caribbean immigrants in New York City. Among these black Caribbean immigrants, they're black, but they're immigrants, when they were told, half of them told, take the test, blacks do more poorly than the test, and the other group, the group told that blacks do more poorly actually did better. So it actually enhanced their performance. They repeated the study among the children of black Caribbean immigrants. Now, the immigrants were not raised in the United States, so they haven't bought into the negative stereotypes about being black. But among the children of black Caribbean immigrants, they found the effect. Those told that blacks do more poorly did more poorly. Their parents didn't, but they did. Showing the power of the larger socialization about a group in society and how it affects functioning. I need to move along here quickly. Let me talk about the most powerful example of racism in America and the one that we never talk about that has the most powerful effects on health. I wrote a paper in 2001 where I said residential segregation was the fundamental cause of racial disparities in health. I'm not the first person to say that. Murdo said it in 1944. John Sell is a historian at Duke University, wrote a book on the origins of segregation in South Africa and the US South. And John Sell argued that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States. Because it's beneath the radar screen, but it has pervasive negative effects on health. If you have listened to recent reports of segregation, they're touting the fact that segregation in the United States 2010 census is at the lowest levels ever in the last 100 years. However, the decline in segregation has had no impact on the very high percentage black census tracts, no impact on the residential isolation of most African Americans, and no impact on the concentration of urban poverty. The decline in segregation just refers to the fact that there were predominantly white census tracts where 2 black families have moved in, so now they're no longer all white, and that is the responsible decline. But it hasn't shifted the fundamental underlying pattern. And you're saying, what does segregation have to do with health? Where you live determines where you go to school. It determines the quality of education. It determines the access to employment opportunities. Where you live determines the quality of housing, the quality of neighborhood environments, whether it's easy or not to be healthy in your neighborhood. It determines whether your neighborhood encourages good nutrition because you have access to fresh fruits and vegetables, or whether it's difficult to exercise or unsafe to exercise in your neighborhood. And where you live determines access to high-quality medical care. So there are multiple mechanisms by which segregation can affect health. Let me give you one example of a study done by David Cutler, a famed Harvard economist, using statistical techniques that I cannot even fully describe. He found that statistically, if you could eliminate residential segregation in America, you would completely erase black-white differences in income, education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. All of that driven by residential segregation. So residential segregation is, in fact, a powerful driver of health. And the point I'm making is, in the United States, you either are living in a healthy community or an unhealthy community. And there are multiple dimensions by which a community can be healthy or unhealthy. And when you live in a segregated community, you're much more likely to be living in an unhealthy community. How segregated really is America? William Julius Wilson and Robert Sampson, 2 sociologists, did a study of the 171 largest cities in America and said there isn't even one city where whites live under similar conditions to blacks. And they concluded, and I quote, "The worst urban context in which whites reside is considerably better than the average context of black communities." How segregated really is the United States? This is the level of segregated in South Africa under legally mandated apartheid in 1991. 90% of black South Africans would have to move to and have an even distribution of blacks and whites in that country. In the 2000 census, segregation in most of America's major cities was just slightly lower than that on the legally mandated apartheid. Moving along. what can we do about racism? I've given you all the bad news. Do we have any evidence that there's anything we can do to make improvements? And the answer is a resounding yes. We can improve health through policies and procedures that seek to reduce institutional racism by improving housing and neighborhood conditions, by increasing educational quality, by enhancing access to additional income, employment opportunities and desirable resources, and by reducing violence and incarceration. All of these are policies that don't look at the individual level, but get at the institutional sources of discrimination. Let me give you one quick example. One of the best examples we have is the impact of the civil rights movement. If we look at the last 50 years, is there any period of time where we narrowed the black-white gaps in health? Yes, between 1968 and 1978. During that time, when the gap in income between blacks and whites narrowed because of the gains of the Great Society programs, the anti-poverty programs, and the civil rights movements, we actually had the health of African Americans improving more rapidly than the health of whites, so there was a narrowing of the black-white gap in terms of health. So it's pretty strong evidence. But let me give you another example. High-quality experimental study that took poor people who lived in housing projects, randomly gave some of them a voucher to move to a less poor neighborhood. 13 years later, remember, no health intervention. All you did was move them from a poor housing project to a less poor neighborhood, no health intervention. 13 years later, they have a lower levels of obesity, lower levels of diabetes risk, better mental health, dramatically improved, no health intervention, just improved their housing conditions. Education policy, there are things we can do within the field of education that can have dramatic effects on health. One of the best examples is what we can do with preschool education. The Perry Preschool, a study done in Ypsilanti, Michigan, took poor African-American kids in a housing project. Again, high-quality design, randomly assigned to receive an early intervention program or not. Preschool, nothing else happened. 40 years later, the African Americans who got a preschool program, higher levels of education, higher levels of income, higher levels of employment, higher levels of savings, higher levels of home ownership, higher levels of marriage, less involvement with the criminal justice, less involvement with the social welfare system, and for every $1 invested, there is a $17 return to society. Folks, what I'm saying is, we have the highest quality of scientific evidence saying if we invest in kids, we improve their academic performance, and we save society a lot of money. If any of you know a place where I can invest $1 and get a $17 return, you don't have to announce it to everybody, but please pull me aside before I leave so I can know where I can get such an investment opportunity. And I'm saying we have that kind of evidence from early, the Perry Preschool intervention. Let me give another example of psychological interventions that need to take place. There are multiple examples. I only have time to talk about 2 of them. The power of this intervention is that it is so simple that it seems to be too easy to have the dramatic effects that it does. It's called a self-affirmation intervention. But we now have 2 randomized double-blind experiments in which 7th graders in schools, black and white, are given an intervention. The intervention is simple. The goal of the intervention is to enhance their sense of adequacy and self-worth and to reduce the power of stereotype threat. So what the researchers do is just tell the students one day in class, here's a list of values. We want you to write about the value that is most important to you. It could be the value of honesty, a value of family, or whatever the value is. Just write about which one you like and why it is important to you. Write a paragraph about it. And what they found, simply by doing that, led to improved grades for 70% of the African American students. It reduced the racial black-white gap in achievement, in grades, by 40%. No effect of the intervention among whites, no effect only among African Americans. They followed the kids for 2 years later, and they found that that one intervention, just one intervention produces the results, leads to sustained improvements in the kids' GPA for 2 years, reduced the black-white achievement gap, reduced the number of black students in remedial programs, By the way, a similar experiment has been done with women in the STEM sciences that finds simply by helping them affirm who they are leads to improved performance academically. So again, the point I'm saying, we now know, published in Science, high quality experimental evidence of the kinds of interventions that work. Another one that's equally dramatic, done by Walton and colleagues, the social belonging intervention, took undergraduate students first year in college. What the research finds, what Walton developed this theory, is that many minority students and many students who are first generation in college, when they encounter difficulties in college, every difficulty seems to reinforce for them that they really don't belong, that this is not for them. Others are doing this, assume others are having no problem, but I'm struggling. Something's wrong with me. Maybe I don't fit. I don't belong here. And so the intervention is designed to normalize the problems you have. And the goal of the intervention is to tell these freshman students, everybody has trouble. It gets better over time. You'll be doing just fine. And to help the students internalize it, they not only give them the evidence, they say this is the evidence from recent scientific research, but we want you to tape it so that you can, we'll videotape you taping it, talking about it, so we can show it to other students in the future. And because the students had to memorize it and learn it and to be convincing talking about it, it was a strategy to help them internalize it. What's been the impact? They've now followed those kids until their senior year. Increased academic performance, reduction of the black-white gap in grades by half, reduced doctor visits, improved self-reported health. When in their senior year, they asked the students about, do you remember if you did something in your freshman year where they talked to you about stuff? The students did not have any specific recollection of the event, but it had dramatic effects upon their health. So it's not the case that we don't know what to do. One of the other things we need to do, we talk about interventions, reducing the health effects of racism. We can minimize the health effects of racism by enhancing the capacity of individuals to cope with discrimination, by maximizing the health benefits of medical care, by helping people to make healthy choices, by enhancing protective resources, and by empowering individuals. In the interest of time, I'll only talk about one of them, give you one example of empowering communities. First Nation youth, Native youth in Canada, have one of the highest levels of adolescent suicide in the world. This study looked at a number of First Nation communities in Canada between 1987 and 1992 and found that although as a group this population had almost one of the highest rates of adolescent suicide in the world, there were some communities had no suicides at all. And so the researchers wanted to identify what predicted variations. And they developed a measure to capture community empowerment and continuity. The 6 markers captured things like, did this First Nations community have any litigation with the federal government of Canada over land and over property? Were they assertive in trying to exercise control? Did they have control over the provision of services to their community like education, healthcare, police, and fire? And did they have a building in their community where they celebrated their culture and taught the younger generation their culture? What this study found, the more of those markers of empowerment a community had, the lower the risk of adolescent suicide. A strong dose-response relationship documenting the higher the level of empowerment, the lower the levels of suicide. Then we need to reduce racism in our culture. There's a lot of things we need to do by what we do within the media in terms of diversity training, in terms of reducing individual level prejudice, but we also need to dismantle racism, and I want to conclude by looking at some examples of positive events and the effects that they might have. So this is just one example, but these are all the areas in which we have to work. Several years ago, as a faculty member at the University of Michigan, we were doing research using the National Study of Black Americans. This is a national study where 4 times between 1979-80 and 1992, the same group of Black Americans were interviewed repeatedly, national sample, 4 times. We found something striking. In 1988, African Americans' health was the best it had been before '88 or in 1992. Their levels of discrimination was the lowest. Their perceptions of whites were the most positive. And we were like, what was happening in '88? And we stopped back because this was 7, 8 years later. And like, in 1988, Jesse Jackson, a black man, was running the most successful presidential campaign ever by a black person in U.S. history. And within the black community, where there was a subtle pride that Jesse was sitting with the big boys and doing well. And we argue that this was a Jesse Jackson effect, a spillover effect from the political climate to health. Well, in South Africa, we have research has documented, not I have, but research has documented a Nelson Mandela effect. There were racial differences in psychological well-being, with South Africans, reporting lower levels of psychological well-being than white South Africans. In the year that Nelson Mandela was elected, 1994, the racial gap in psychological well-being was eliminated, reflecting dramatic increases in the perceptions of happiness and life satisfaction about South African blacks. Sadly, 18 months later, the effect was gone. So an effect was there, but both, as we saw with the Jesse Jackson effect, it was also short-lived. I was certainly intrigued of could there be a Barack Obama effect. And one of my students, who's a professor at the University of Cincinnati, found a data set, called me all excitedly. She found a data set where we could look to see if there's a Barack Obama effect. And that is, there was a large study in Ohio that started in August 2008 and ended in January 2009, interviewing thousands of citizens of Ohio every week. And we decided to use a design looking over time, seeing if major events in the campaign were linked to improved health. And what we found, the measures of health were not ideal. We only had a measure of self-rated health, but we thought we wanted much more of a psychologically oriented measure. But we were able to document higher self-rated health for both blacks and Hispanics in the state of Ohio linked to Obama's nomination for president. There was no effect for his actual election or for his inauguration, although the study ended 3 days after his inauguration. Let me conclude. I've given you some examples that racism in its multiple forms has emerged as a major risk factor for health. We need increased research to understand fully its potential effects. We need to implement feasible and optimal strategies to effectively mitigate its negative effects on health. But I think our biggest need is to create a political will and support to dismantle societal structures that support racism, ethnocentrism, anti-immigrant sentiments, and incivility. And I leave you with this call to action from Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. We need to change the world to reduce racism in American society, to promote the health of all, and give every American the opportunity of the American dream. And I believe that we are a small group of thoughtful, committed citizens. We can begin it right here. Thank you very much. We have a few minutes left for questions. Any quick questions or comments? Yes?
Do you know of any evidence about the effects of denial of racism and denial of discrimination on members of minority populations? So does that increase distress of racism?
Nancy Krieger is a colleague of mine in my department who has found work that an early study she did looked at the relationship between discrimination and blood pressure. And she found a U-shaped relationship that women who reported high levels of discrimination had higher levels of blood pressure, and women who reported no discrimination also had high levels of blood pressure. And she thought one potential explanation of this is that, not everyone who says they haven't had it is in denial, but maybe one pattern driving that could be denial. I think so. It's a hypothesis out there. As of now, we don't have good evidence. Nancy Krieger is doing something very innovative as well. She has adapted the IAT test to try to get implicit reports of discrimination, so the reports of discrimination that people are unable or unwilling to report. I would say she's developed the measure. To date, it hasn't proven as empirically robust as we would ideally have liked, but we're not sure exactly what it is getting. So I think finding ways to develop a measure of denial is important. Any other questions? Yes, at the back. Yes.
What do you think about racialized pharmaceutical health? We hear about the lack of heart drugs and things like that. There are hundreds of drugs being separately tested.
Yes. So Bidal would be the example of a drug, the first drug and only drug to date approved by the Food and Drug Administration for the treatment of a heart problem only in blacks. It was driven, there have been lots of analyses done on Bidal, it was driven by a way for the pharmaceutical industry to make more money. And they co-opted the Black Association of Black Cardiologists to help perform the study. So, I mean, there are really powerful economic interests at work. What we know, so for example, any good clinician knows that blacks and whites respond differently to antihypertensive medication. Any good clinician knows. If you have a parent who's a physician or nurse, ask them. Everybody knows that. The question is, what's the evidence for that? If you look at the clinical trials that have been done, there are small average effects between blacks and whites. So there is some truth to the conventional wisdom. However, there is the variation within whites in response to hypertensive medication, and the variation within African Americans is 3 to 4 times larger than the small mean differences. Basically, simply knowing the race of a patient provides you no scientific information of what kind of medication to give them. And I think we still live in the world where we think that race captures biology, and I think that is in part a driver of that. That's a quick answer. We could talk more, but that's a quick answer. Any other quick question, comments? Yes, right in front. Yes. On the discrimination tools. So the measure of discrimination, I ask people these questions. After they've responded to them, I ask them, what do you think was the main reason? Which allows someone to tell me it was their race, their gender, their sexual orientation, their religion, their social class, so we can capture all types of discrimination. What we find in general with discrimination in both the US and South Africa, that younger people, younger minorities report higher levels of discrimination than older ones, which seems to be surprising because the older ones lived under Jim Crow. So, but it may well be, it makes sense if you stop and think about it. If you are in South Africa, let me pick South Africa, it's easier for us not to think about ourselves. If you are in South Africa, and you are the gardener, and you go do your job and stay in your place, there is no need to discriminate against you. In fact, as Mary Jackman, a social psychologist who taught me in graduate school, says, discrimination only comes into play when people are stepping out of line. It's to put you back in your place. So that discrimination then is positively associated with social class among African Americans, because African Americans of middle class are more likely to interact with whites as equals. If you're interacting as subservient, there's no need to discriminate against you. You're in your place. So it's stepping out of your place that gives the problem. There's also an issue with age about expectations. I mean, for some people, the Jim Crow laws was just the way life was. I mean, it wasn't, so it's kind of what are your expectations, what you expect. But it's a great question. I think we have time for one more question. Yes. So you've asked a good question, and it's a fitting for the last question. But let me say, it allows me to say a couple things. One is, I think we need to attack racism at multiple levels. And clearly, any one of the strategies I illustrated, and there are many more that I didn't have time to talk about, that there's empirical evidence for, Any one of them alone is not going to be the magic bullet that will solve the problem. But what I was trying to illustrate, there are lots, a lot of times people think there is nothing we can do. We don't know anything to do. And I'm saying there's a lot of empirical evidence pointing to things that we can do and we know will work and we know will save society money. So there's a much we can do. Certainly, what we need to do is to reduce cultural racism. And so we have to look at the media and the ways in which the media operates and reinforces some of these negative stereotypes. These negative stereotypes that people have. The fact that people have negative implicit biases doesn't mean that you are a bad person. You are simply a product of your society. You are just reflecting how you have been socialized, how you have been taught by the larger cultural agents in your society. So we need to do that. We need to dismantle the institutional structures. So we need to think of what we can do to improve the quality of schools. But even for the teacher teaching students in a segregated school today, we now know of strategies that teacher can implement for a classroom. But implementing it only for a classroom doesn't solve the problem. It'll solve the problem for those kids, but not for everybody. So I think that the important point for all of us is that there is something that each of us can do to make a difference. And we can work together to make America a better society and to realize the dream that we all want to live for now and for the future. Thank you so very much for your time and attention.